So kia ora koutou, I think we'll make a start. Just like to welcome you all to a seminar series. It's for us very exciting to be restarting these HSRC series, seminar series, which had stopped since before lockdown, first lockdown. Just to let you know that this is being recorded and the recording will be made available on our website, as there are a number of people who weren't able to come today. But it is really lovely to be able to see people in a face-to-face seminar environment. It feels like it has been a long time. So our talk today is called Concentrations of Complexity, and this has been a collaborative piece of work, and it's going to be presented jointly by myself. I'm Mona Jeffries, a Senior Research Fellow at Te Wellington, the Health Services Research Centre just upstairs, and Tessa Senior, who is a research assistant with us at the moment, as well as a student at the School of Health.
Oh, sorry, I'm coming. I don't have a microphone on this, do I?
Sorry, was there a question from Zoom? Slides are not so as I mentioned, this was a collaborative piece of work. So the other people involved were Maite and Jackie from Victoria University Wellington, who both work with us, and Kenny Ho and Peter Crampton from the University of Otago. I'd just like to acknowledge the funding which came from the Royal New Zealand College of GPs Research and Education Committee, as well as the HSRC programme grant on enhancing primary healthcare services, which we currently hold at the centre. Can I just ask, I was just going to say, can I ask those of you on Zoom to mute, please, because there's a bit of distraction coming through over our speakers. There's a couple of you there who aren't muted, so if you could do that would be great. Thank you. So as background to this study, then what we're interested in is whether the current model of primary healthcare funding is equitable. So what we're really looking at this is on a practice level, not on an individual level. So as a bit of background, then capitation funding began in 2001. So what I mean by capitation funding is funding which comes from the government through DHBs and PHOs to general practices, and is given on a per capita basis. So for every person enrolled at a practice receives a certain amount of annual funding for that person. And this replaced a fee-for-service model where essentially you paid as you went to the GP. There still are co-payments by patients, as you all know, and those can vary from very little or nothing to $70, $80 or more for a visit. There's a lot of nuances to the capitation funding, and Tessa's going to go into a lot of those details as we go through the presentation. But very broadly, there are two types of practice, and these are don't cover all the practices, because there's also there are other types as well. But most practices are either VLCA or not, and VLCA stands for very low-cost access practices. Now, those are practices which the government gives a higher level of capitation funding per person enrolled in return for the practice guaranteeing to cap the fee which they charge, the co-payments which they charge. And currently for an adult aged over 14, that's capped at $19.50. Some of those practices do charge less, and they're at leave to do that, but they're not allowed to charge more. To be a VLCA practice, a practice needs to serve a population which is more than half what we call high needs patients, or I shouldn't say, we call what has been defined as high needs patients. That means patients who are either Māori, Pacific, or living in the most deprived quintile, what we call NZ-DEP5. And just a quick sideways step for those of you who aren't familiar with that, acknowledging that I know that June Atkinson and others who have developed these measures are online, are So this is a way of measuring area level, the small area level deprivation. Small areas are then ranked across the whole country and broken into 5 equal chunks. So when we say NZDEP5, we mean the 20% of the small areas in New Zealand which are most deprived being based on 9 census level measures such as unemployment and overcrowding, that sort of thing. So coming back to VLCA, to be a VLCA practice, you need to be serving what we might consider as high needs patients. So in one of those 3 categories, and clearly with some level of overlap. There is a very complicated funding formula that defines the level of capitation funding that a practice receives. And that takes into account a number of different factors. As I said, Tessa is going to go into those in more detail. So why might it matter that different practices get different amounts of money? Well, it doesn't take much to imagine that patients who have got higher needs, have got more chronic conditions, therefore probably do have higher levels of utilization. We're talking mainly here about GP utilization, but obviously also practice nurse and nurse practitioner utilization as well. And just as an example, then, if you're treating a patient with diabetes, then you're expected to monitor their blood glucose regularly. If you're treating patients with asthma, you're expected to offer multiple return appointments to make sure that their treatment is optimized. So when you have a group of patients which on average has got a higher prevalence of these chronic conditions, you would expect them to use the services that you're providing at a higher level. But the capitation funding doesn't really take that into account, because all it does is say, this is the age-sex breakdown of your patients, and so we're going to give you a certain amount of money. It doesn't tell us anything about, other than the age determination of chronic conditions, so that the older you get, the more chronic conditions you may have on average, then the funding formula doesn't take into account these high needs patients. I should say the basic funding formula, the basic capitation formula, because there are more nuanced additions, which we'll look at in a moment. So our research question was whether general practice capitation funding accounts for what we call the concentrations of complexity. So when we've got a higher proportion of high needs patients, the concentrations of more complex and a higher level of chronic conditions. And I'd like to acknowledge Peter Crampton, who came up with this lovely phrase, concentrations of complexity, and we have kept on using it hijacked. So we're going to look at 4 different sets of data to try to understand and answer this question. We're firstly going to look at the prevalence of chronic conditions across what we call high needs compared to not high needs patients. We're going to look at the level of primary healthcare utilization among these people. We're going to look at unmet needs, and by that I mean barriers to primary healthcare. So when we know that somebody needs care but is unable to access it. And then we're going to look at practice level funding. So I'm going to look at the first 3 sets of those results, and then Tess is going to look at the practice level funding and explain what she's been working on. So the data sources for the first part I'm going to describe to you come from the New Zealand Health Survey. We wanted to use data that was pre-COVID-19, so we're using the data from the 2018-19 Health Survey. This is a survey of about 15,000 patients, which is conducted, it's actually been in the field for a long time, and since 2011 has been in the field constantly, and every year then a set of data released by the Ministry of Health. The data are weighted to allow the results to represent the results of Aotearoa New Zealand, weighted in terms of the respondents in terms of age, sex, and ethnicity. The data that Tessa is going to show you, a lot of it comes from the PHO Services Agreement dated July this year, as well as publicly available distribution of high user health cards and community services cards that are on the Ministry of Health website. And as I said, then in determining what is allowed to be a VLCA practice or not, then high needs is used to describe people who are either Māori, Pacific, or living in NZDEP5. And I'd just like to acknowledge that that's not our term, that's a term that we've adopted from the VLCA definition. So for the New Zealand Health Survey data I'm going to show to you, we're going to look at utilisation, which is the number of GP visits in the last 12 months. So this is self-reported. People were asked to remember how many times they've been to the doctor in the last 12 months. We're going to report on the presence of chronic illness. So there was a list of 10 common chronic illnesses that people were asked to say whether they had ever been diagnosed or treated for. And we're also going to look at unmet need. And the unmet need question is people who answered that they had had a need to see a GP in the last 12 months, but had not been able to get care. So across the country, then, on average, people visit the GP 3.1 times per year and a nurse a bit less than once a year. But we know that that isn't the same across the whole population. We know that GP utilisation rates are higher for women than for men, particularly for younger women. We know that utilisation rates are higher for high needs people and for older adults. Similarly, nurse utilisation rates are higher for older adults, for Māori, possibly for Pacific people, although that's not showing up in the New Zealand Health Survey data, and for women living in more socially deprived areas. And that's interestingly not the case for men in socially deprived areas. When we look at the proportion of people who have 3 or more chronic conditions, so that's over on the right-hand side of this graph, then we can see here we've got the bars of the high needs people in blue and the bars of the not high needs people in red. And we can see that for people who have... Sorry, could I just ask again that anyone on Zoom could mute, please? Thank you. So we know that we can see here that people who are high needs patients are more likely to have 3 or more chronic conditions, or to report 3 or more chronic conditions. You can also see that people who are high needs patients are less likely to report no chronic conditions. That sort of sounds a bit like it's self-evident, but you have to remember how we're defining high needs. This is actually not really based on need at all. It's based on ethnicity and where you live. We then want to look at how many times patients who are high needs see their GP. So you remember that I said on average people see their GP just over 3 times per year. If we look at the high needs patients again, here shown in blue, then we can see that high needs patients are much more likely to visit their GP 7 or more times, or to report having seen a GP 7 or more times in the last 12 months. And if we add up these 2 bars, then the high needs patients, about 8.7% report going 7 or more times compared to 6.6% of the not high needs patients. So I've just noticed there's a chat come up, so thank you very much. That's a comment that we'll address in the questions, so appreciate those comments coming through on the chat. I'd also just like to highlight here the difference in not having seen a GP at all in the last 12 months. And we can see here that this is probably what we're talking about when we talk about unmet needs. So these are people who probably did need to see a doctor, but weren't able to go. And that might have been because of cost, might have been because of other barriers as well. We don't know exactly why. So when we look at chronic illnesses, then we can see that for a number of different chronic illnesses, then there's a much higher prevalence in people who are high needs patients, and that's particularly evident for asthma and for type 2 diabetes, which I'm sure isn't a surprise at all for many of you. But actually what we're interested in here is not those specific conditions, but we're interested in the burden of disease. So we looked at people who had 3 or more chronic conditions, and nearly 15% of people who are high needs reported 3 or more chronic conditions, could be any 3, compared to about 12% of the not high needs patients. So we can see then that patients who are high needs have clearly got a higher level of chronic disease burden and a higher level of utilisation. Then when we look at unmet need due to cost, then we can see here on the top 2 bars So these are people who say that they needed to see a GP in the last 12 months, but didn't because of cost. We can see here that about 18% of people who are high needs reported that, compared to about 11% of those who are not high needs. When we look at transport as a barrier to getting primary care, we can see that that's reported much more frequently in those who are high needs. It's about 6% compared to 2%. And when we look at being unable to get an appointment at all, whether that's with a GP, a nurse, or other healthcare worker, we can see again that that's more prevalent or more common in people who are high needs patients. So in summary then, we can see that patients who are high needs have got a higher burden of chronic disease, a higher level of actually seeing the doctor, as well as a high level of facing barriers to see a doctor or a primary healthcare worker when they need to. So that really sets the scene for what Tessa is going to present. And I'd just like to acknowledge the huge amount of work that Tessa has done. She's come in as an undergraduate, been given this project and has really taken it and flown with it. It's been really fun working with her. It is still in progress, so we're not quite, we haven't quite finalized all our analysis yet, but it's got some really interesting results. So I look forward to letting Tessa share them with you.
Thank you. Hello, everyone. So I will be sharing with you the next part of our results, which is the hypothetical practices. So we have 4 of them. We have a practice that has 30% high needs patients, so 70 not high needs, and then 50% high needs, so half is and half isn't, and then 70% and 90% proportion of high needs patients in these hypothetical practices. And we are assuming the practice is 5,000 patients. We've taken 5,000 as kind of an average. And as Mona spoke about earlier, this information is from the enrollment data. So we like to think we can, our results are representative of the actual population, because the spread will be from accurate enrollment data. So I'll talk through each of these pools as I get to them, but just as an overview, each practice gets capitation funding, as we spoke about earlier, and the VLCA practices are separate practices. So you're either VLCA or you're regular, essentially. And VLCA, yep, so that funding, and then there's community service card funding, high user health card, and something called zero freeze for under 14s. So this is actually 2 hypothetical practices. So we've got in blue, this is the hypothetical 5,000 patient, 100% high needs practice. And then in pink, this is 100% not high needs. So this is essentially giving the distribution of age and how that differs. Because as we know, Māori have a greater spread, their age spread is a lot higher towards younger people. And for non-high needs, there is a lot greater spread of older people. So it's just an interesting representation of, obviously the capitation funding formula is based on age and sex. So for our 4 hypothetical practices, this is the rate of capitation funding they would receive. As you can see, and this is our 5,000 practice of hypothetical patients. The 30% practice gets roughly, so annual funding of the base capitation, they get roughly 8,200. And as we go up and jump 60% of high needs enrolled patients, we go up to $818,000, which is in that much of a jump of need. And as we spoke about the concentration of complexity and prevalence of chronic conditions, there's not a huge jump in the capitation funding to account for that. So high user health cards they are something the GP applies for on behalf of the patient, and the patient must have visited the doctor or nurse. Actually, I can't be sure of that, so I'll take that back. The GP 12 or more times in a year for an existing chronic condition. So high user health cards are essentially for high needs people who do have those chronic conditions. But as you can see, for a start, this here, so annually, not even $2,000, like that's not a huge amount, it's quite a small income, and it actually goes down the higher the amount of high needs patients, which, as we spoke about in these statistics earlier, we know that high needs patients visit the GP 12 or more times more in the high needs category. Community service cards, there's been a recent-ish 2018 policy that actually tried to make community service cards more of a more impactful for high needs people. And again, they kind of aim to service high needs people and help them with access. Reasons for having a community service cards: being on a lower income, being on a housing benefit, and being older is actually shown to be a determinant of receiving a community service card. So this is the funding, and we see it does increase with percentages, but the 90% practice doesn't quite have 60% more funding as you would potentially expect to see. Just some statistics for how many people have a community service card. In 2018, there were 818,000 people who had one, roughly 12% of which were Māori. And fees free for under 14s. This is reasonably self-explanatory. If you're under 14, you don't have to pay co-payments, and obviously the practices get this subsidy for them. And just to note, VLCA practices, for the sake of our study, we're saying that they do not get this because that is apparently incorporated into their VLCA funding. But there are some practice level policy that means some of them may, but most of them don't, because that's included in VLCA funding. So onto the VLCA funding, and as we spoke about earlier, very low cost access practices are designed essentially for high needs people, because you have to have 50% of enrolled people being high needs. And that technique can span. So you have to have half of your enrolled patients high needs, but the other half could not be as well. So they were introduced to combat access for high needs people because, as we spoke about, you have a capped co-payment if you're part of a VLCA practice. And hence we haven't modeled the 30% practice because that wouldn't exist because you have to be more than 50% high needs. And note that the formula for VLCA funding is the same as capitation. So it's done on age and sex. Despite catering for a different population, the formula still uses age as one of its only determinants. And yeah, as you can see, the 90% practice has a lower level of funding than the 70% practice, likely due to the distribution of age again. And this is the two, so this is a non-VLCA practice, and I have made a mistake by leaving this 30% one in here because they wouldn't get 30%, and that was something I was supposed to do this morning and I haven't. But just ignore that, And yeah, so this is the funding level for non-VLCA practices. So it sits just below the 1-2 mark, and then here we see VLCA sits just above the 1-2, so not a huge amount of difference there. So in summary, for this part, high needs patients have greater utilization, multimorbidity, and unmet need. VLC funding adds significant but does not account for the varying levels of need. Community service cards have added, but not a significant amount to the funding. The same with high user health cards. It's very minimal what they add. And the capitation formula does not account for the age spread of high need populations. So this, I just stress, this is not our work. This is the work of Sapira, who wrote a report on to estimate the underfunding of Māori in healthcare. Really interesting report. But so they have also modelled 5,000 people for practices, and they included the co-payments, which we haven't. And they address a 5,000 patient practice. This would be the normal one, so the non-VLCA, and this would be the VLCA income, including the co-payments, which, as we can see, the overall total income for this hypothetical practice is less for VLCA patients. And they also say in their report that they have VLCA practices have a higher patient turnover and higher patient complexity, as we addressed earlier on, and a much higher amount of unpaid co-payments. So when you take that into account as well, their income just goes down. So in conclusion, capitation funding alone does not account for the concentration of complexity. Funding formulae that rely on age and sex demographics are not sufficient in accounting for utilisation associated with high needs populations. And the funding model for VLCA practice can financially disadvantage these practices for trying to help high needs people. And there is evidence of structural discrimination in the health sector based on the funding available to practice who serve high needs populations. And I believe that is it. If there's any questions, we would love to answer them.
Have you looked at all at the impact? So what?
Impact of
On the patients.
On the patients? We haven't actually. I think
What does it mean to be in a practice that has less income?
It would mean, I suppose we're assuming that higher level of chronic conditions, and you would get less access to appointments and less time with the nurse or the GP.
What does that mean though in terms of your health outcomes?
That is true. Ona, can you answer that question?
No, we haven't. It'd be quite difficult to, I guess, to do on a practice level, given this frustrating lack of individual level health data on a GP practice level that's not available nationally. We could probably look at it in terms of hospitalizations. And so we are doing another bit of work as part of the programme grant where we're looking at aspects of practices. And so that will include VLCA and non-VLCA in terms of outcomes on hospitalizations.
And ED attendance as well.
And ED attendance, because so we certainly know that people who face barriers to primary health care very often end up in ED. So yeah, that is an interesting one. It's quite tricky to do. So we've got Megan, who's sitting at the back there, is an experienced statistician, as well as another person in Auckland who we're collaborating with. So we're working together on that, but it's pretty early stages. Yeah.
What age breakdown are you using for looking at the relationship between high needs and age? Because you need a fairly detailed age breakdown to that.
So the breakdown of ages is taken from the Pieto agreement. So it is the Ministry of Health funding age bands. So I think it's 0 to 4.
But I was thinking of 65 plus. Is there a breakdown within that?
There isn't, which is a great point. That is not, because as
high needs.
that's true actually.
And the Ministry of Health has an island.
No, so as far as I'm aware, when it comes to the funding brackets, it's just 65 plus. So,
Yeah, which is really interesting when you think about that.
Yeah.
The difference between a 65-year-old and an 85-year-old in terms of needs. Absolutely, yeah.
So there are some additional funding sources available for specific programs.
Like long-term condition, yeah. There are, but when you look at the impacts that things like high user health card has, which you think should be, I'm astounded when I look at that y-axis. I think, why did we miss a couple of zeros off the end there? It just seems to have a very little impact. So yeah, it'd be really interesting to see if those other smaller pots of money and things like services to improve access equally have any. Well, that is the problem. Can I just address some questions here in the chat? So the first one is from Bridget. I understand that the nurse visit rate is recognised as being an underestimate, as many nurse consultations are not captured in the utilisation data. So that's absolutely true. So the nurse utilisation data that we use comes from the New Zealand Health Survey. And the question that they ask in the health survey is about the number of times you've seen a GP with or without a nurse, and the number of times you've seen a nurse but not seen a GP. So clearly there is nurse utilisation that's not being captured there if you also saw a doctor at the same time. So that's a good point, Bridget, thank you. Then from Alan Moffat, pretty sure that high user health entitlement includes nurse visits. So thank you for clarifying that, that's great. From Lynn, is income based? The high user health card, it's not income based, it's based on utilisation as far as I know. From Fiona, when VLCA was introduced, it was open to all practices. So there are VLCA practices with less than 50% high needs.
My understanding was when they were introduced in 2006, it was anyone could apply. And then in 2009, they specified you must be 50%. Is my understanding.
Thank you. From Jeremy, is there any breakdown of rural funding? Now that's a really interesting one.
Which I forgot to mention that there are pools we didn't include because we thought either it was so hard to quantify or like a service to improve access, it's applied for on each case. And I'm afraid rural funding is one we haven't included because the statistics weren't there that I could find to know how many practices are rural. So it was really hard to find that information, I'm afraid.
From Jim, I understand this is about primary care. However, utilisation of hospital services, ED, visiting and inpatient admission may also need to be looked at. So a fuller picture of the patients using health services can be obtained. So that's what we were speaking about earlier. Thank you. From Alan, CSC card is income based. So the CSC card is not the high user health card. That's right. The other thing to point out is that utilisation for virtual consultations during COVID were not initially being captured. Now, this is a really interesting one. So we took our data from prior to COVID for exactly that reason, but I think that there is work going on, not so much by our team, but by others looking at the utilisation of virtual consultations, both phone and Zoom or video calls. So I think the funding of that, I think, is not well understood because it's not captured on a national level. From Peter, it appears that capitation formula does not take into account the premature and compressed morbidity of Mare and Pacifica, but assumes age is a good measure for waiting for morbidity. Absolutely, I mean, that sums up, I guess, the last hour beautifully. So, thank you. It's absolutely true. From Fiona, did your research highlight the inequity between VLCA and CSC formula for the same capped fee? I'm not sure of the inequity in funding to the practice, which is what we've been looking at. So my understanding is the VLCA, everybody in the practice can only pay up to the capped amount. For the community services card, it's an individual level policy. So an individual needs to apply for the community services card. And then that is, if it's not a VLCA practice, that is that capped amount is applied to the individual, but not practice-wide. But I'm not completely sure I've answered your question there. So if you want to add more into the chat, Fiona, please.
Yeah, no, can I talk?
Oh, absolutely, yes, hello.
When we developed the CSC formula at PSAP, we realised there was a huge inequity between what VLCA practices were receiving and what is essentially fee substitution revenue compared to what they would receive for a CSC. Because when we introduced CSC, we were effectively buying out the average co-payment of those people. So we ended up with a much larger amount in CSC because it was a more realistic buyout of the co-payment value. It highlighted how underfunded VLCA practices were for the same capped co-payment of $19.50.
Oh, thank you. Is that written up anywhere by any chance? Well, it sounds really, really
No,
interesting.
but I could easily do that for you.
Oh, that would be really interesting too. Thank you.
You don't know it's Chiquita here in the crowd, Fiona. I was just trying to remember what the utilisation has been since that community service card changed. And I know we were tracking it for a year or two, but
It's been lower than the anticipated.
lower than anticipated because we were really worried when that policy came in. That would be enough funding, would be too much funding.
It was lower than anticipated, but the impact of COVID.
It was interesting in that change as well. VLCA doesn't get anything more for under 14s as well. So it was taken away from then, even
Although
though.
most DHBs have provided some additional VLCA
Okay,
and urgent care.
that's helpful.
And the other one that's really interesting, high use healthcare in some areas has been not promoted because it comes out of flexible funding for some PHOs and these flexible funding for a variety of different programs that are different from the high use healthcare because it's good in some practices. People using the high use healthcare ones no some actual assessments and care plans. So I think the high use healthcare does not put data to look at anymore. Fiona, do you think I'm right about that? Well,
Yeah, I know it's got very low uptake at the moment. There's also the issue of rewarding people for being frequent flyers.
Yep.
Yes, yeah. Interesting.
A couple of other points here. One of the issues we don't capture is SU by CSC nationally. Not certain what SU is. Service utilisation. Ah, sorry.
Service utilisation. So we provide quarterly, I suppose it's monthly now, I'm not quite sure, reporting to the ministry, but it doesn't break down by CSC, non-CSC. So we haven't been able to track accurately at a national level any increase in utilisation associated with reducing the co-payment for CSC card holders to $19.50. The one that we were able to track was when we introduced zero fees for under 14s. It was originally under 13s. And the average service utilisation was something like about 1.78 per annum for under 13s. And when we put the zero fee, it went up nearly up to 2.2.
Wow, it's quite a change. Yeah.
When we look closely at that, it was 2.2, not necessarily the population that that policy was trying to affect, by memory.
Yeah, well, that's always the problem, isn't it? That a policy doesn't necessarily do what you want it to do. What it has done, the CSC policy, I think, is to significantly reduce the level of unmet need due to cost for Māori, but hasn't for Pacific people. So that's really interesting that it's possibly because Pacific people are already mainly served by practices which are VLCA practices, but may not be. So that's. Alan, I don't know if you heard that. Liz suggested you may have a comment about that, but don't feel you have to add in or not. I just feel like I've missed a couple of comments back here. From Jeremy, current funding models for rural do not work for lots of reasons. Good point, read data. Recent publishing of geographical classification of health will enable better data collection and support further work. Just because analysing it is hard, should support more analysing rather than excluding. Yeah, totally agree. Super. So are there any other comments? There's no more comments in the chat. Anything else from the audience?
I suppose if you had a magic wand, what would you do? You know, around the capitation, because that's the base funding.
Yeah.
Nice to dive into data and look at sort of top of mind.
I think one thing that stood out to me when you look at the international literature as well and how other places, countries weight their funding, and it's not just on age and sex, it's on illness. Not all of them or a lot of them, but I think there is a push towards to weight it by illness or by illness or condition. That would be my magic wand, would be to actually look at it a little bit more just granular it down a little bit to cases rather than age and sex, because that's clearly not a very good indicator.
We've been arguing inequity and the relative adjuster.
And I would say
For a number of years now, isn't it, Fiona?
Certainly.
So we would hard to hear the people in the room. It's a wee bit echoey. But just bearing in mind that the capitation formula, the base capitation formula, is the only universal part of the formula. So I call it universal funding, but actually it's just a small component of the funding. Now it's based on historical utilization rates by age and gender. There was no weighting in it for any level of deprivation or health need. It's just, that's a universal part of it. And then they tried to add bits onto it to try and address those other things. And they introduced VLCA, obviously, to bring down costs. They introduced Care Plus to sort of address some of the funding that was required to address long-term condition management, and various things have happened along that way, but it's just grown topsy-turvy. We've tried to sort of plug holes in it. We've ended up with this formula that doesn't actually work for anyone anymore, and we've been calling for it to be reviewed. I think 2018 was when we first started that journey, and successive governments have said, yes, oh, we're going to do this, we're going to do that. And the latest one, oh, we're rolling it into the review of the health and disability system. But unfortunately, it just pushed out the whole process of completely reviewing the way that we fund primary care until now, which is great. So research is really valuable. Thank you.
Thank you. Good to hear.
So the other point that we should highlight is that this is actually around 5% of health system funding.
The primary care funding. Yes, so just for those of you on Zoom, just to reiterate what Liz just said, that 5%, the primary care funding is about 5% of the vote health budget, which of course is, yeah, I would agree with that one. Yes. Lovely. Well, I'd like to thank you all very much for an interactive session. It's really great to get interesting feedback when you give presentations. So I appreciate everyone's comments, and yeah, and many thanks again to Tessa for all the work she's done and a lovely presentation.
Thank you.
Thank you.